Thank you. In 2007, 2008, we had children in South Florida that were having health effects and seemed to be temporarily related to the use of caffeinated energy drink products. As someone who helped run most of the last decade one of the larger children's hospitals and a large safety net public service hospital system, we put together a working group to really try to see were the safety signals that we were finding at the bedside really of concern or not. One of the first things we did in our working group was we had the director of our South Florida Poison Control Center interrogate that database. We found that in the preceding year there were 39 2 to 20-year-olds that were tracked for health concerns within the South Florida Poison Health System. We tracked in the state of Florida. We found it was 125, including hospitalizations. That led to us, that was not for energy drinks, that was for caffeine. At the time, the Poison Control System really had no reporting mechanism for energy drinks in the United States. We then went on and interrogated the national poison data system for the United States, again focusing on caffeine. We found that it affected pediatric patients and often required symptomatic treatment. This is moderately severe symptoms, life-threatening effects, deaths, 2006, 2007, 2008, and there were deaths in all years. There were symptoms in about 10% that were considered moderately severe as coded in the national database. And in terms of really in children less than 6 and children 6 to 19, that represented, at least in 2007, 46% of all the reported cases in that system, and we published that data in Pediatrics. We then became aware that the Substance Abuse and Mental Health Services Administration was collecting data that was put out in their Dawn report earlier this year of U.S. emergency department visits involving caffeinated energy drinks in patients aged 12 years and older. And their data, not ours, suggested that this was increasing exponentially from 2005 to 2011. The upper part of this graph were adverse reactions or side effects to use of energy drinks documented in the chart. The bottom graph, misuse or abuse as relevant to energy drinks, broadly defined to include all visits associated with inappropriate use of energy drinks. We then, as we were trying to explore in our working group in Miami whether this was really something we need to anticipate, plan for, try to prevent in other vulnerable populations, we started to say data should guide policy. What's the data? We again found the United States Poison Control System at that point had not been tracking energy drinks. We said, has this been tracked elsewhere in the world? We found that it had been. Some of the examples that we published in our report was the German Federal Institute for Risk Assessment had been assessing it from 2002 to 2008, and they found serious disease effects in their registry, including death. Ireland, the poison system, we found from 1999 to 2005, also had energy drink adverse events, including death. New Zealand poison centers from 2005 to 2009 had adverse events reported, including myocardial infarct. This resulted in us having further conversations with, in terms of whether other global tracking for energy drink issues. We found that in Australia, in the New South Wales region of Australia, all the poison control centers from 2004 to 2010 had been tracking calls to individual poison centers, and they found a steady increase in accidental pediatric ingestions of caffeinated energy drinks. The upper line here represents recreational, which are intentional ingestion for the purpose of gaining euphoria or other psychotropic effects, and accidental pediatric in green which again are non-deliberate ingestion by a person under 18 years of age. In the paper that they reported this past year, in fact, over time, both of these have been reported with increased frequency. So again, adding another country around the world that had formal tracking mechanisms showing the same trend. This type of information led to us in 2010 starting to speak with those experts who track in the United States and run the National Poison Data System. We were pleased that on their own they saw the need to, by the safety signals in their data system, to start tracking energy drinks. We recently reported, I think last week or so, the data from the first year of their reporting, again, throughout the entire United States from October 1st, 2010 to September 30th, 2011, 1,480 non-alcoholic caffeinated energy drink poisoning cases were what we were dealing with, and half the poisonings involved caffeinated energy drink related toxicity involving exposures by children less than 6 years old. And that's where we broke it down by age. This is 0 to 5, 6 to 12, 13 to 19, and 20 plus. In the same study, where we looked, we found that children less than 6 years old had the highest proportion of unintentional exposures to non-alcoholic energy drinks, whereas teenagers had the highest proportion of intentional exposures. Again, on the far right here, unintentional was used by the NPDS as misuse and differs from intentional misuse in that exposure was unplanned or not foreseen by the patient. We then found that the New Zealand Food Safety Authority had tried to put together risk profile data in 2010. We're looking at exposure to caffeine from energy drinks or shots available against a background dietary exposure from naturally occurring caffeine in foods and beverages and cola-type soft drinks. And what they found here was that the proportion of children, teenagers, and young males with potential caffeine intakes above the adverse effect level of 3 milligram per kilogram per day of one retail unit of energy drink shot consumed. And what they found here was after consuming a single retail unit, 68% of children, 42% of teenagers who consumed caffeine were estimated to exceed an adverse effect level of 3 milligram per kilogram body weight per day beyond their baseline dietary exposure. And again, that's what's shown in this bar graph. They then went on to look, in this case, at 13 to 19-year-old individual teenagers and tried to use these models to give feels for with one retail unit, 2 retail units, 3 or 4, where the adverse effect level is. You know, and I'm not a big believer in anecdotal case reports, but just as an example here, one of the published ones of a 13-year-old girl with no known medical history of cardiac disease consumed a 16-ounce can of an energy drink in this published report, contained 160 milligrams of caffeine, a caffeine exposure of 4.1 milligram per kilogram per day, presented in the emergency room with palpitations, chest pain, shakiness, and dizziness. And after extensive testing, she was diagnosed with the long QT syndrome. Why am I bringing that up? Because, in fact, in the United States, as much as we like to say that we believe in well child care, we don't do a very good job of routine screening for underlying heart disease and other susceptibility. And that's where, when Dr. Saul mentioned yesterday that there's about 500 kids and teenagers and young adults a year that have sudden cardiac death in the United States. Many of them at autopsy are found to have underlying cardiac disease. Many of those really had no idea they had it. The American College of Cardiology recommends restrictions for activities that increase adrenergic stimulation for groups at risk of sudden cardiac death. And when you look at some of the causes of sudden cardiac death in young athletes, they list them here, and it's a lot of the things that have been discussed so far. But But one of the things is I'm a pediatrician, I'm a pediatric cardiologist in particular. You know, for children that have congenital or underlying heart disease, children that have incessant ventricular tachycardia. I'm a cardiomyopathy specialist. I run for NHLBI, the Pediatric Cardiomyopathy Registry. Hypertrophic cardiomyopathy is on the list. Again, oftentimes children have this. They're not aware of it. Sometimes the first event is a terminal event. Sudden cardiac death, long QT, as I just presented, as was just mentioned. It's not that you always see it, but you can see it occurring sometimes based on a provoked scenario, but unclear. You look in other cases, in the case of other stimulants such as amphetamine for the treatment of ADHD, risk groups have been recognized by other regulatory groups. February 2005, Health Canada suspended Adderall XR due to concerns about increased risk of sudden cardiac death. August reinstated Adderall, but with revised labeling that identified rare heart-related side effects. In May 2006, FDA directed manufacturers to strengthen warning section of labeling. And again, the whole issue comes up for those that are in this conundrum of taking care of kids that may need these medicines but may have underlying heart disease. How do we balance this? It's not really crystal clear how we do that, but again, stimulants in general, whether it's in the form of a prescription product, whether it's in the form of a caffeinated energy drink product, remain a concern for vulnerable populations, which is what I was asked to cover. So how do you know if a child might be at risk of adverse cardiac effects from caffeinated energy drinks and should avoid them? Unfortunately, routine physical exams for high school athletes do not identify everyone at risk for sudden cardiac death. As was mentioned yesterday, it is almost unheard of that for pre-participation sports physicals or general well child care, the question even comes up about energy drink consumption, and whether that's appropriate or not is subject to debate. But on top of that, we really, on top of history and physical, ECG and echocardiography are not routinely assessed in children in the United States. So again, if we have something that has therapeutic efficacy, great. If we have something that increases risk and we see it consistently, that's a potential concern, especially when we don't clearly have the ability to screen everybody for cost reasons who may be in a high-risk category. So as part of our working group, we got a lot of pediatric primary care doctors and subspecialists together in our working group, and we asked them, you know, most of what we do, unfortunately, in clinical medicine is based on consensus and expert opinion, and we really don't have RCTs to guide probably 90% of what we do, at least in child health. So we asked some of our specialists, you know, high blood pressure occurs 3 to 5% kids in the United States. If you have a child who's on antihypertensive therapy, we heard yesterday the NPDS 2010 to 2013 of the poison control calls around the United States, 2.5% were related to hypertension. So would you, knowing that that's the case, want to advise your hypertensive patient that you're caring for to avoid energy drinks, consume them, or no effect? You know, within our working group, the feeling was if I had a child that I have on antihypertensive therapy and this has a blood pressure elevating effect, we probably would want to suggest that they avoid using that product. Is that scientific? It's as scientific as we can get in the current circumstance. Is it ethical to do a study to really answer that? Probably not. Effect on seizures and syncopal disorders, same thing. When you look at the NPDS data from 2010-2013, 24 of the reported poisonings involve seizures. If you have a patient that's on anticonvulsant therapy, a child that has probably a lower threshold for seizures, would you, as the child's neurologist, suggest it's okay to consume energy drinks? Our panel thought not. Same thing for syncope, as Dr. Saul, an expert yesterday, pointed out. He routinely advises his patients with syncope who are children to avoid caffeinated products. issue that came up again, about 10% of the kids in the United States are diagnosed with ADHD, 70% are treated with prescription therapy, commonly stimulants. Oftentimes there's a nice therapeutic effect. Are stimulants on top of stimulants likely to give even better control? If that was the case, you'd increase the prescription. Our experts felt that that potentially could be a concern. Brought up earlier today, the issue of caloric intake diabetes. It has a lot of effects. There are plenty of reports of children needing to be hospitalized unaware of the high sugar content who are being treated for diabetes, but it's not necessarily on topic here. In terms of effects on children and adolescents with eating disorders, again, it was another area brought up by our adolescent health specialists, that this is one area where, for a lot of reasons mentioned earlier and throughout this meeting, we would not be advocating. And, and is there confusion about sports drinks, energy drinks, and have national organizations come out and that this is not something to be used in the setting of hydration and can exacerbate events? The answer is yes. In 2008, I said that until research establishes their safety, energy drinks should be banned not only from schools, but from purchase by children and teenagers. In the same way that sales of tobacco and alcohol are controlled, this approach is essential to save lives, encourage research, and support families. I have had nothing to do with the American Academy of Pediatrics expert group that published that has no place in the diet of children. I have had nothing to do with, again, it's the largest probably organization of pediatricians in the world. The AMA just a month and a half ago voted that marketing for under 18 should be suspended for these. And what do those type of campaigns do? Well, what we just published was when our report came out, and Dr. Arias and a couple of others, there was a lot of media attention, a lot of discussion, which is what we wanted to promote. We looked at the NPDS, poisonings around the United States. There had been a significant upward slope. With an intervention, it was significantly changed. What happened when the FDA for alcohol energy drink issued the request to not sell those? We found in the NPDS a real difference in the number of poison control calls. So, I know my time is close to up here, but where there's not real strong therapeutic benefits for children less than 18 for use, and there's suggestions, no matter which global database that we can find, for potential for certain subgroups that may have serious adverse events, and that a lot of this is understudied and poorly regulated in terms of what's the cause and effect in there. Again, we're just looking more population-based, broad, large. Are there safety signals? There's absolute safety signals. It's consistent in every study that we could get our hands on. And so, I think that for this type of situation, we think that there are probably vulnerable populations, and children seem to be one of them, and subgroups of children with underlying disease represent another. Get into this later, but there's a lot of opportunities here for further research. But what Dr. Taylor was bringing up earlier about GRAS and different interpretations becomes important. As a pediatrician, as somebody who's run one of the largest children's hospitals for a decade, I take it that it's part of my responsibility to try to protect children when I see safety signals until I really know that there's an opportunity to have a therapeutic real benefit. Thank you.